I thought it might be interesting to look at a few cases of cutaneous apocrine cribriform carcinoma. Now, I put the term carcinoma in brackets with a question mark, largely because from the limited material or information available on the web, I haven't come across any cases that metastasized, and so it's certainly a very low-grade tumor, and whether it's frankly malignant is up for debate. And the most important thing about the tumor is excluding the possibility that it might represent a metastasis from a mammary carcinoma. Apocrine carcinoma of the breast is very rare. I think it only accounts for maybe 1 or 2% of breast tumors. But nevertheless, if you see a case in the skin, it's always very prudent to make sure it's not a metastasis. Having said that, it's a tumor which I'll show you in a moment or two is instantly recognizable and a very pretty tumor. It's interesting that it shows a predominance for females, and most cases arise on the extremities. In fact, over 80%. And patients present with a firm or hard, sharply delineated nodule. It's painless. It's asymptomatic, and it varies in size, but can be up to 1 or 2 or 3 centimeters. And histologically, it's characterized by a variety of cellular patterns. As you can take from the title of the tumor, it obviously shows cribriform areas, but in addition, it may show well-developed tubules. Sometimes one see a bridging pattern with little tiny micropapillae, and then you can get solid patterns, and the solid patterns can sometimes be a little bit challenging. The tumor, if you like, shows its apocrine derivation by the presence of eosinophilic cytoplasm, and if you're really lucky, you might find a foci or a focus of decapitation secretion. One of the things that characterizes this tumor, and this is shown very nicely on the right from a case that Professor Chi Shun Yang showed me from Taiwan. It shows the tumor, but then there's some dense connective tissue around it associated with dense lymphoid aggregates. And these lymphoid aggregates are a common feature of the tumor and should raise this possible diagnosis when you see them. The other thing that's really important in terms of differential diagnosis from adenoid cystic carcinoma, with which it's sometimes confused, is the absence of myoepithelial cells. As you'll remember, adenoid cystic carcinoma is a biphasic tumor. It's composed of epithelium and smooth muscle cells, so their absence obviously points you towards cutaneous apocrine cribriform carcinoma. So I'm going to show you a few cases, and this is one that Eduardo Calongi shared with me, and this is absolutely typical. Small cells with eosinophilic cytoplasm, uniform nuclei, and forming this cribriform or almost lace-like pattern with thin bridging strands crossing from one side of the tubular structure to the other. And that field that I'm just circling with my cursor, that's typical of this tumor, and I think it's instantly recognizable. It's a very delicate lace-like growth pattern, and there's a higher power view. You can get a bit of mild nuclear pleomorphism, as we see in this field on the right side. The nuclei are enlarged and irregular and hyperchromatic. And there you see this beautiful lace-like pattern, which I think characterizes the tumor best. And in the cases that I've seen, they've all had this. And when you look down the microscope and you see that, I think you automatically say, oh gosh, this is another cribriform carcinoma. And there's EMA outlining the ducts. And here's another way. Oh, this is the case that Dr. Chi-Shun Yang shared with us. This is a medium power, and it looks awfully like the one that Eduardo showed to us. It's uncannily similar. And there you can see there's a sort of a suggestion of decapitation secretion. If you look just towards the top of the image, round about the middle, you can see eosinophilic cytoplasm bulging into the lumen of this ductal or glandular space. And there's another little focus there. And so I think this is very suggestive of an apocrine tumor. And then when we look at the epithelium itself, it's abundant, it's pink, and it's granular. But the tumor lacks the significant pleomorphism, and it lacks the mitotic activity that you would expect to see in a cutaneous apocrine carcinoma. And there's another close-up view. And there, and again, you can see these little delicate strands of epithelium crossing from one side of a glandular space to the other. And again, you just look at that, and it's an instant spot diagnosis, I think. And then this is one that Dr. Sasi Atili shared with us. And the low power is absolutely gorgeous. You can see it's well circumscribed. It's got a fairly sharp border at the top. And then when you look at the tumor mass, it's an instant spot diagnosis. Look at that cribriform lace-like growth pattern. It's everywhere, and so I think by now this is the third case that we've looked at. You should be recognizing this at the drop of a hat. And there's the bottom of the lesion, and there are the lymphoid aggregates that I mentioned in the lower right-hand side. And there's a close-up view there showing the cribriform growth pattern. And here again you can see the cytoplasm is abundant. The staining is a little bit not quite right in this image, so it's hard to make it out clearly. But I think again, if you look in the bottom left-hand quadrant, you can see what looks like the beginnings of apocrine decapitation, secretion. So that's another typical example. This case was quite interesting because it showed very marked stromal hyalinization, which I hadn't appreciated could be a feature of these tumors, but one lives and learns by seeing more and more cases. And there's a close-up view showing that very delicate lace-like growth pattern. As for the immunohistochemistry, I think the most important thing really is smooth muscle actin, muscle-specific actin, and calponin negativity in apocrine cribriform carcinoma, because that tells us that the tumor does not have a myoepithelial cell layer, and secondly, it's GATA3 negative, whereas in a breast cribriform carcinoma, that would be GATA3 positive. The other immunohistochemistry, I don't think has much to offer really. It's interesting that from what I can see, cutaneous apocrine cribriform carcinoma is negative for the ETV6 NTRK3 fusion gene. And then differential diagnosis. Well, I think the most important one, when you've excluded a breast tumor, the only other one worth thinking about is adenoid cystic carcinoma. And there are, particularly with the solid areas of cribriform carcinoma. So this is a rather solid area from an adenoid cystic carcinoma, and you can see something that is instantly recognizable, and that's this eosinophilic mantle which lines the inner surface of pseudocysts, and you never see that mantle in cribriform carcinoma. And then the other, again, this case from Dr. Chi Shun Yang, this one is smooth muscle actin, showing you the myoepithelial cell there. So I think with those two differentials, if you exclude those, then the diagnosis is fairly straightforward. So I hope you've enjoyed this video. Now, if you've encountered some cases of cribriform carcinoma, it would be really good if you could mention that in comments, because it is such a rare tumor, and I'd love to hear anything you have to say. So thank you very much for your attention.